Okay, so we're going to talk about something a little bit different. In all of these pulse sequences that we've talked about so far, the first thing that we did was turn on an RF pulse, which I'm going to go back to 90 degrees just to keep things simple. But obviously, it doesn't, as we've already learned, it doesn't have to be 90 degrees. It might be some smaller amount of rotation of the transverse magnetization. And following this, at some point in time, which we called TE, we sampled the signal. And during this period of time, we had to have our slice select gradient on. We had to phase encode. And centered on the period at the point in time at which we sample the signal, we have to have the frequency encoding gradient on. So this is our slice gradient, phase gradient, and frequency gradient. And what would we call this whole procedure?
Gradient.
Okay, so we have a dispute. So,
gradient.
This is a gradient echo pulse sequence because there is no 180 degree RF pulse. If we wanted to make this a spin echo pulse sequence, TE would become a little bit longer. And in between the 90 and TE, we would turn on a 180 degree RF pulse. Sorry? And that would be slice selective. Thank you. Right. Okay. So this is a spin echo pulse sequence. So what happens now if I do the following? So I've turned on a 180 degree RF pulse before we ever generate the signal. So what does that mean? Well, we have our magnetization, which if the B0 is going from floor to ceiling here, it's at rest. When we give it a 180 degree RF pulse, it rotates down to 90 and keeps going until it is inverted from where it was at rest. That's the definition of a 180 degree RF. At this point in time, if we would sample and listen for signal, how much signal would we be able to detect? Zero. Why? Because the definition of a 180 degree RF pulse is that there is no net transverse magnetization. There's no signal. So if we do this, does it have any impact on the signal that we ultimately measure at TE? And how? Well, let's look at what happens. So the definition of that 180 degree RF pulse is that our magnetization looks like this when we start out. And if we follow it over time, it is going to recover in approximately 5 times T1. Now, in the pulse sequence diagram, what it's telling us is that we give that 180-degree RF pulse, and then what happens to that magnetization? First of all, when it recovers from this point, it does not rotate back through 90 degrees. Okay? We knocked it down to 90 degrees, past 90 to 180. That's not the trajectory of the recovery. Because if you think about it, we're at 180 with no net transverse magnetization, no phase coherence. If we're just observing what's going on and not applying any additional RF, any additional energy, we cannot generate any net transverse magnetization, any phase coherence that isn't there already. So the trajectory of this relaxation is that it shrinks to 0 and then regrows. The whole time with no net transverse magnetization. So what this curve represents is that inversion and then regrowth through 0 of the longitudinal magnetization, never having any net transverse magnetization throughout that entire period. Okay? Then, in our pulse sequence diagram, we said that at some point afterwards, we're going to give this 90-degree RF pulse. Well, let's say that the point at which we give the 90-degree RF pulse is right here. What that means is that at the time that we give the 90-degree RF, we have this much longitudinal magnetization to turn into signal, to turn into transverse magnetization, which is detectable as signal. Less than if we had never done this in the first place. Remember, if we had never done this in the first place, we would have started out with a large amount, right, our fully relaxed longitudinal magnetization. So one thing that we can say in a general sense about this approach is that whenever we put a 180-degree RF pulse on the front end of our pulse sequence, we're going to have less longitudinal magnetization and ultimately less signal to sample at TE. So this approach, whatever it might do for us, it's always going to be a lower signal to noise measurement. So why would we do this? Well, let's make up an example where we have two different tissues. And let's say that the red one is muscle, and the green one represents fat. Maybe this is from an MRI of the leg or something like that. Well, if we then start out by giving our 90-degree, our 180-degree RF pulse, the next thing we have to decide is where are we going to place our 90-degree RF pulse. If we place it over here, where we started out before, there is a very similar amount of longitudinal magnetization from both fat and muscle. When we generate that signal, they will have similar longitudinal magnetization, generate similar amounts of transverse magnetization. If we change the location of our 90, we can generate much greater amounts of contrast between those two tissues. That contrast is a function of what? The T1 of the tissue. So the second thing we can say about this approach is that it gives us a new way to confer contrast that's based on differences in T1, or to make an image appear more T1 weighted, so to speak. What if I make my 90-degree RF pulse over here? Well, at this point in time, the curve describing the recovery of longitudinal magnetization from fat is crossing 0, which means there is no longitudinal magnetization present at that moment. At the time that we turn on our 90, we turn on the RF, it generates signal only from things that have longitudinal magnetization. In the absence of longitudinal magnetization, no signal can be made. So this image would then have contrast, which is a function of the longitudinal magnetization from muscle and the fact that we have no signal from fat. This would essentially be a fat-suppressed image. Okay? Now, this approach is called inversion recovery. This time between the 90 and the 180 is called the inversion delay, time to inversion, sometimes goes by the letter tau. And that parameter, which is a new parameter we haven't dealt with yet, is going to alter the T1 contrast in our image, first of all. Second of all, it will affect signal to noise. The longer that TI, the more recovery we have before we get to the 90-degree RF pulse, the more longitudinal magnetization, and therefore the more signal we'll have in our image. But also importantly, the judicious or injudicious choice of TI can cause you to eliminate signal from something. So in this case, where the TI is relatively short, this is a short, right, TI inversion recovery or STIR image. And one of the characteristics of STIR images is that they are fat-suppressed images. Right? For this to work, of course, you have to choose exactly the right TI. And remember, for example, we said the other day that the T1 of a tissue, of all tissues, is partially related to, right, determined by field strength. So this inversion delay that might work at 1 field strength, say at 1 Tesla, is not, the same number is not going to work at another field strength, 3 Tesla. And in fact, this is a number that really needs to be optimized on kind of a scanner by scanner basis, because there can be very slight variations in the static magnetic field. Now, on the other hand, let's add something else in here. Let's add something with very long T1, like cerebrospinal fluid. So if we choose to place our 90-degree RF pulse at this point in time, we generate an image where we have no signal from CSF. Right? And you guys know that as a FLAIR, or fluid-attenuated inversion recovery image. If there's some tissue whose signal you want to suppress, that you don't want to see that in your image, you can choose an inversion recovery pulse sequence with the appropriate TI to suppress that signal. So, for example, while this isn't in wide clinical use, once upon a time there was a report of a technique that was called FIRM. And FIRM stood for fast inversion recovery of myelin. where the TI was chosen to suppress signal from myelinated brain tissue. It was used in kids to differentiate myelinated and unmyelinated white matter. The fast part, forget about. We'll talk about that a little bit later on today. Okay. Now, one other feature of inversion recovery that we need to be cognizant of is, let's say that instead of muscle, well, this could still be muscle. But let's say within this lower extremity or whatever it happens to be, there is also a soft tissue tumor, say a sarcoma, which we already saw on Monday, that a soft tissue tumor might have very similar T1 and T2, or at least T1, to normal muscle. It might be very hard to detect. And one of the things that we will do to try and bring out the appearance of the tumor is to give a contrast agent. We talked about how the contrast agent will take this T1 relaxation curve and essentially shift it to the left, so that the contrast-enhanced tumor might have a T1 that looks like this after we give our gadolinium contrast agent. Well, if we do that and we use STIR, short inversion recovery, what happens? We generate an image where we've suppressed the fat, and we have also suppressed the signal from the contrast-enhancing tumor. So this is generally not an advisable way to do fat suppression if you're going to be using a contrast agent. Now that's a little bit of a problem, because one of the main roles of fat-suppressed imaging, as the people who do clinical imaging know, is to be able to see contrast enhancement in areas where we have lots of fat. The fat has very high signal on a T1 weighted image. The contrast-enhancing abnormal tissue has high signal on a T1 weighted image. If they're both embedded in each other, it's hard to tell them apart. We'd like to get rid of that fat signal. This is a way to eliminate signal from fat, but is not a good idea if you're using a contrast agent. So we're going to have to go on and look at other ways to potentially suppress fat if we want to use contrast. But this is inversion recovery imaging. That's really all there is to it. Any questions about this? All right, let's look at some pictures. Okay, so these images are the same person in the same session being imaged using a spin echo inversion recovery pulse sequence, the same one we just diagrammed, changing the TI. So if you look at these images with a TI ranging from 20 to 950, what can you see? First of all, for those of you that are used to looking at brain images, most of them look relatively like T1 weighted images, right? The gray white matter contrast. When you get into this range of like 130 Ti, and maybe more so at a TI of 200, what do you notice? That the fat, first of all, in the scalp, in the orbit, drops out. The signal vanishes. All of this white stuff in the orbit, or in the subcutaneous fat, which is present at the shorter and the longer TIs, is being suppressed. That's because we have fat crossing its null point around the time that we're giving that 90-degree RF pulse. Right. Similarly, we talked about myelin. Notice that if you compare the other images where the gray matter is darker than the white matter, If you compare those to those around the null point for fat, notice that the gray-white matter contrast is reversed. There's lower signal in the white matter than there is in the gray matter. This has to do with the fact that we are also hovering around the range of where myelin is crossing zero. This point, meaning this time from the 180 until one of these T1 curves crosses zero, is referred to as the null point. And if you want to suppress some component of the image, you want to choose the time between your 180 and your 90 so that you are giving your 90 at the null point. Okay, this is just an example of some stir images. Right? So this is an upper extremity with a tumor involving bone marrow and soft tissue. We can see that the fat, normal subcutaneous fat, fat between the muscles, is black, and that the fat within the bone marrow is also suppressed, which allows us to see the tumor, which is very high signal. Right? This is a non-contrast image, but certainly within the marrow, this would be very hard to detect if the fatty bone marrow was very high signal, as it would be on any other T1 weighted image. Now, aside from trying to use inversion recovery to suppress signal from tissue, it's also very useful for generating contrast. So this is a stir image of the brain on the left, and you can see that it just gives us extremely good contrast between gray and white matter. That's simply a function of the T1. The subcutaneous fat, notice, is black. That's not the reason why it was used in this case. We really didn't care about the scalp, but it gives us very good contrast. Similarly, this is an image called MP-RAGE, okay? So this stands for rapidly acquired gradient echo. This is just a T1 weighted gradient echo image. But it's not just a T1 weighted gradient echo image, because on the front end of this gradient echo image, we have added an inversion recovery component, added a 180-degree RF pulse, whose purpose is to bring out contrast between gray and white matter based on their different T1. The MP stands for magnetization prepared, which is just a way that someone thought of to describe inversion recovery. So you can actually think of this idea of inversion recovery imaging as not really some pulse sequence that is unique unto itself, but it is a component that we can stick on to the front end of pretty much any other pulse sequence. Whether we're doing gradient echo, spin echo, or other things that we'll talk about later on today, you always have the option of adding inversion recovery simply by placing a 180-degree RF pulse at the front end of your pulse sequence. If you look at that little menu page, there's a section called preparatory modules. And this is one of several things that we can add on to the front end of the pulse sequence to do various things. Modulate contrast, suppress signal from specific tissues.
So why would you choose that way to bring out, if you're not interested in the suppression, why would you choose this way to bring out a T1 contrast?
Well, this image without that component would also be a T1 weighted image. But the gray-white matter contrast would not be nearly as good.
Can you show why that is?
Can I show why that is? So we could, you mean, could we diagram why that is? Sure. So let's look at it this way. If we think of our typical spin echo or gradient echo approach, let's say we're going to give a 90-degree RF pulse, and we are going to have two tissues which recover at different rates. So if we choose our 90-degree RF to, excuse me, if we choose our TR, forgive me, Right? In this case, we could choose some TR at this point so that we were always repeating this, right, at a point where we had a maximal difference between longitudinal magnetization and therefore signal of these two, and that would give us a T1 weighted image. Okay? If instead if we start with inversion recovery, right? So this is our starting point. At some point along here, we're going to give our 90-degree RF pulse, which we might choose, you know, somewhere around early on. There's going to be a much bigger difference between the longitudinal magnetization of those two.
Okay, so you just stretched out the contrast in a way, or the differences between
We've
T1 required.
emphasized the differences in the contrast. We've made them more apparent. Right? So whenever you do inversion recovery imaging like this, you're always going to be enhancing the T1 contrast in your image. All right?
You could never get that contrast without that inversion recovery.
Not that degree of contrast. Right. Okay? Now, so here are two other images. These are FLAIR images, fluid-attenuated inversion recovery images. And you'll notice that I've indicated one of these is a T2 weighted FLAIR image, and one of these is a T1 weighted FLAIR image. You guys are familiar with FLAIR, right? At least the radiology people. T1 FLAIR, is that something you're familiar with? No? Okay. We tend to think of, and this was its original use, of FLAIR images as images that are essentially T2 weighted. The contrast between gray and white matter is such that the white matter is darker than the gray matter, which is characteristic of differences in T2. But unlike your typical T2 weighted image where the CSF would be very high signal, we null the signal from CSF using inversion recovery. And that allows us, for example, to detect lesions that might be along the border of a CSF-containing space, like this thing, which is a little MS plaque. This would be very difficult to see if there were extremely high signal intensity throughout the ventricle. We do this by applying a 180-degree RF pulse, followed by a long delay. Right? That long delay is because the T1 of CSF is long, and we are interested in hitting our excitation at the point where CSF is at its null point. This inversion delay here at 1.5 Tesla is on the order of close to 2 seconds. Okay? Then in this image, while we do want the inversion recovery to null CSF, we're really interested in predominantly T2 contrast. So these are done with a very long TR. The TR might be more than 10 seconds. Your typical T2 weighted image might be done with a TR of a few seconds. Right? So the purpose there is that if we wait a really long time TR, everything is fully relaxed. And when we repeat this a second time, there is no sort of built-in persistent T1 contrast. Since this inversion delay, this TI, is very long, while it's taking a long time for CSF to get to 0, the tissue that we're looking at has a much shorter T1, whether it's gray matter or white matter or whatever it is. So by that point in time, we've largely recovered most of our longitudinal magnetization from the tissue component of the image. So that's why these so-called T2 weighted FLAIR images really don't have a lot of T1 contrast in them, although they certainly do have T1 contrast in them. And the fact that the CSF is black is 100% a T1 contrast mechanism. So what's this idea of T1 weighted FLAIR images? Well, this looks like a T1 weighted image. Compared to your sort of typical spin echo T1 weighted images, the contrast between CSF and tissue is much greater. The CSF is much blacker. You get these images with this beautifully jet black CSF that nicely outlines all of the sulci. So how do we do this? Well, it's really the same idea. It's an inversion recovery pulse sequence where we have a 180, a 90, right, TE, and then TR out here. We still need to have a relatively long TI because the purpose of this inversion recovery piece is in part to suppress CSF. Right? So we still want to get this when CSF is crossing its null point. However, we keep the TR relatively short, which means that by the time we get to TR, right, all of the tissue components have not fully relaxed. And when we give the next 180-degree pulse, they each have different amounts of longitudinal magnetization that's been recovered. Is that clear? So by keeping the TR short, there's T1 contrast that's now built in when we go back and give the next 180-degree RF pulse. And then the fact that we're using this inversion recovery component gives us even a greater amount of T1 contrast. So T1 FLAIR really dramatically enhances the quality of these T1 weighted images, both in terms of minimizing signal from CSF, as well as enhancing signal, for example, between gray and white matter. Question?
So then you can only do it if the graphs are the way you drew them, where the 0 point is where the other two have recovered completely. Because like if you were to shift the 0 point to the left, then you wouldn't have the 0 points on the CSF, then you wouldn't have a complete recovery of the other two components.
Well, the 0 point for CSF is where it is. I mean, in other words, it takes a fixed amount of time, depending on the field strength and the T1, to get to the null point of CSF.
Which, for that to work, does it have to correspond to the fact where the other ones have completely recovered their longitudinal?
I'm not sure what you mean by does it have to.
Like, if they haven't, then you would be at a point where you are... You do it twice. Where your contrast is not...
Well, let's put it this way. If we have some component of, I mean, this is kind of hypothetical, but if we had some component of the tissue which had a relatively long T1, okay, so that's going to have relatively little longitudinal magnetization at the time that we give the 90-degree RF pulse. The signal from that tissue, whatever it is going to be relatively suppressed. But on the other hand, this approach will bring out contrast between this tissue and the others. But that's a T1 contrast. My point was just that we look at this image, and if we ignore the CSF, the contrast in the image looks like a T2 weighted image. For this to be a T2 weighted image, we need two things. Well, first of all, we do use a long TE, right? That's easy. But we also need to minimize T1 contrast. Well, that's a little bit of a conflict because we said earlier that any time you use an inversion recovery preparation on your pulse sequence, you're conferring T1 contrast on that image. All I was saying is that if our inversion time is extremely long, then most of the stuff that we're interested in, the tissue, has already almost fully recovered by the time we ever get to this 90-degree RF pulse. So it's functionally like we don't really even have an inversion recovery component for that tissue. If it wasn't like that, then the situation would be that we would have a significant amount of T1 contrast in the image. Doesn't mean you couldn't do it. It would just change the appearance of the image. Does that answer your question? Okay. So CSF signal is eliminated in these images based on the fact that we know the T1 of CSF, and we know how long it will take from a 180-degree RF pulse with that T1 for us to be at the null point. Now let's look at this example. So here's a bunch of T2-weighted FLAIR images. So in these images, we expect, if this is T2 FLAIR, and assuming we did things correctly, we should have no signal from CSF. Which means that if we look at the sulci, which should be filled with CSF, right, we should see black in the sulci. Now in this case, if you look at these sulci, you can see that many of them at least, right, are outlined by these bright white lines. Do you see this? Right. Actually, these are probably better examples. So what's going on in this case? Well, if we're talking about inversion recovery, CSF does this. We need to give our 90-degree RF pulse here at the null point of CSF in order to eliminate signal from CSF. Well, this is based on knowing the T1 of CSF. If there's something in the cerebrospinal fluid, that can alter the T1. And if the T1 of CSF looks like this, or looks like this, when we give our 90-degree RF pulse, we actually have a substantial amount of longitudinal magnetization. So this actually is a patient with subarachnoid hemorrhage, which typically, right, has been thought of as something that you really don't see very well on MR images, that we're not very sensitive to it. It turns out that using FLAIR, you're exquisitely sensitive to the presence of subarachnoid hemorrhage. Because when there's anything in the fluid, anything in the CSF, that alters the T1, and all of a sudden, we don't suppress it. Right? This is for the radiologist, right? So here's the CAT scan in the same patient. So we tend to think of CT, right, as being the modality that's most sensitive to subarachnoid hemorrhage. So in this case, which was proven by an LP, you didn't really see anything on the CT, but it was detectable with FLAIR. Right, this is just another example. That's our patient with subarachnoid hemorrhage. It doesn't have to be subarachnoid hemorrhage. If there's an exudate, if there are cells in there due to meningitis or tumor, same thing can happen. Or in this case, this is a child who is under anesthesia during the MRI scan. And as all good anesthesiologists do, they give the kid supplemental oxygen so that he remains sufficiently oxygenated, more than sufficiently oxygenated. So this is a well-known, right, some people call it an artifact, whatever you want to call it, that we see high signal in the cerebrospinal fluid because the PO2 in these kids is so high that the dissolved oxygen in their cerebrospinal fluid goes up and alters the T1 of CSF. Okay?
Can we now routinely recommend T2 FLAIR images for rule out subarachnoid hemorrhage?
For rule out subarachnoid hemorrhage? So if you ask me, I think it's a more sensitive test. And it's been studied somewhat. You know, like everything else in radiology, there are really no good large studies, but the data that's out there seems to show that it doesn't really miss.
But it will be affected by the age of the subarachnoid? It's only
Definitely.
for acute subarachnoid.
Well, no, not necessarily. In fact, it may be more sensitive in subacute subarachnoid hemorrhage, perhaps, than CT, because CT is definitely less sensitive as time goes by, right? But as long as there is some residual something, whether it's protein or whatever it is, in the CSF, you'll have this effect.